You're watching Supporting Your Registrar to Practice Evidence-Based Medicine, produced by GP Supervision Australia and presented by Dr. Skye Baugen and Dr. Justin Coleman. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
I'm Dr. Justin Coleman, until recently a board member, a board director of GPSA, and always a big fan of GPSA. And funnily enough, my other hat is very much the same as the hat of our special guest tonight. So we have Skye Baugen, and Skye is a GP in Orange, and the hat we both share is that we're both senior medical educators with the RACGP in these last 14 or so months since it transitioned to college-led training. And Skye also teaches medical students
at Charles Sturt University here in Orange.
Wonderful. And Skye teaches evidence-based medicine, amongst other things, to those students and registrars, and now to you. So very happy to welcome you, Skye. Well, Skye, I'll let you kick us off with what this webinar is all about. Thank you.
Thank you very much, Justin. I'm well aware, given that I'm teaching people at all levels about evidence-based medicine, from medical students all the way through to supervisors, that this is a topic that people find challenging either to get their head around or to work out how to teach it to other people. And so I'm really hoping that by the end of this, you will be able to, first of all, discuss the key principles of evidence-based medicine and also some of the challenges of applying it in general practice. And I really want to talk throughout about how you can create learning moments with your registrars so that you're not feeling like you have to teach them everything there is to know about evidence-based medicine, but that you'll be finding appropriate points in their learning journey where you can help them along the way, and you'll probably learn things as well. So if we are going to be teaching our registrars EBM, it's really important that we have a shared understanding of what it's all about. So the definition of evidence-based medicine we tend to use is that it's the integration of best research evidence with clinical expertise and patient values. So there's a common misunderstanding or misconception that it's all about the evidence. And the good news is that we actually really need to use both individual clinical expertise and the best available external evidence. And neither alone is really enough. And we also need to make it patient-centred. If we don't use clinical expertise and patient preferences, then we're really at risk of just that cookbook medicine. And we know that even the best evidence might not be applicable to our patient in certain circumstances. But if we don't use the best available evidence, then our practice really risks becoming dated and we risk putting our patients at harm. So a lot of people find this model a little bit confronting and they say, well, where does clinical judgment and clinical expertise come in really? Because doesn't that just take us back to intuition, which was what evidence-based medicine was trying to get away from? But some of the original authors of the seminal paper on evidence-based medicine who came up with that definition refined the model later on. And they said there's actually a really central role for clinical expertise in integrating these other components. So they proposed that actually we're melding together best available evidence, patient preferences and values with our clinical context. And it's our clinical judgment that brings all of those things together. That's how we weigh up these factors and help us to come to that sort of final decision or recommendation that we make or give to the patient.
And certainly, Skye, I do see that sort of resistance to EBM sometimes I think is a bit misguided, because some GPs do feel that it's people telling them what to do and it's this cookie cutter medicine where you just have to go by the algorithm all the time. And look, occasionally it is misused like that, I think. So you do have, certain, when you have health pathways and things, which I think is generally an excellent resource, but, sometimes it really frustrates you if you have to tick one particular box, which you shouldn't tick in this patient's case, but they won't let you through to the end. So once you apply EBM on a grand scale to big systems, I think sometimes there are frustrations about it, but I don't think that's the core of the use of EBM.
Yeah, that's right. And I think this is one area which I'll get to later where our supervisors are really key because our registrars often know what the guidelines say and they find that comforting to be able to follow a list of rules. But we're really good at working out when to apply those rules, how to apply those rules to our particular patients. And that's probably the best thing that we can actually teach our registrars in practice.
We all do it every day, whether we know it or not, which I think is true. It's part of registrars, what they do, their raison d'etre. And certainly someone mentioned we don't want to become quacks. We don't want to become quacks ourselves. We don't want our registrars to become quacks and causing no harm. I think we're all lucky if we can cause no harm. I guess we're weighing up and causing the minimal amount of harm which is possible to do while we're actually still treating people. The cynical answer, because I'm told it is important, well, absolutely, it is still important to treat the individual.
Yeah, absolutely. And if you're applying evidence-based medicine properly, you really are individualising that care. And I also think it helps us to continue our lifelong learning. If we know how to read evidence and look things up for ourselves, it actually does help us with our lifelong learning journey. So we've looked at some of the reasons that we need to teach it. So what are some of the barriers, do you think, to us teaching it in general practice? What are the barriers that you find?
I do find there is a certain resistance to the concept of EBM, although I think if you nut it down and have a one-on-one discussion with the person who's resisted, in fact, often they are practicing what I would consider EBM. So we've got various barriers. We've got lack of confidence in teaching this stuff, time, pressure from patients and carers, and I guess that's implying there can be pressure sometimes to practice non-evidence-based medicine. I would add also increasingly probably other health professionals add some pressure to practice non-evidence-based medicine. We hear on forums like GPs Down Under, when the naturopath sort of sends the patient in with a list of 15 tests and we've only heard of half of them. The sheer number of guidelines, so keeping up with it all and then changing over time and not having access. And when people say access, what we probably mean as GPs is at our fingertips access, because we all know we've probably got access. If we had one question and we wanted to spend 2 hours finding out about it, we probably could all find the answer, but that doesn't necessarily help us in our day-to-day practice.
This is what I had. So time was the first one on my list as well. And I think we all feel that pressure of time. So I'm hoping that we'll be able to teach you some ways that you can actually just use it during part of your everyday interactions with your registrar. So rather than feeling like you have to sit down and give them a full-on tutorial, I'll be showing you points in which your clinical supervision kind of intersects with teaching EBM. Knowledge, lots of people feel that they have a lack of knowledge. And in a survey that was done a while ago, lack of time to teach was about 13% of people thought that. Lack of knowledge, about 15%. A few others thought they needed more training in how to teach it. So they might have felt their own knowledge was okay, but they didn't know how to teach it to registrars. Certainly access to resources can be one. And sometimes that's a matter of, as you say, Justin, about knowing where to find them and where to find them quickly. And people were concerned about the relevance in general practice. And certainly that has been a problem in general practice because a lot of the evidence out there is done on quite narrow populations of people, might be hospital-based. A lot of guidelines are either written for the hospital context or they're based on papers, which are studies done on patients in hospital settings. And our patients are complex. They have all this multi-morbidity, and so you'll sometimes have 2 guidelines telling you to do completely the opposite thing. Sometimes it can feel challenging to find how to apply evidence in general practice. So again, we're going to be having a little bit of a discussion about how we can overcome some of these barriers. And I hope that you'll go away feeling a little more confident and having a few resources up your sleeve to do that.
There was a comment trying to see through lobbying from Big Pharma and Big Food. I certainly think it is true that to some extent the evidence we have, particularly early on about anti-pharmaceuticals, and some of you may know I've done a lot of work in this space trying to improve our scepticism of early evidence for medications. Inevitably, I think medications come out with more of a bang than they probably deserve in the long term, and the majority sort of come back to the pack. I mean, medicine's obviously vitally important to do wonderful things, but the amount of good they do is almost inevitably overstated, particularly early on in the course of a medication. So I think it is something to bear in mind that a lot of the very high quality evidence produced out there is very expensive to produce, and it does tend to be produced by companies with a lot of money, and those tend to be the companies producing that thing. So
yeah, and look, it is one of the really valuable things about upskilling yourself in evidence-based medicine, because you then feel much more confident in looking at what pharmaceutical companies are telling you and being able to see what the strengths and what the weaknesses are in that as well. So some people might say, well, why me? Why is it my job? Why isn't that the training provider's job to teach it? And if it really is my job, well, how do I go about doing that? So why me? Well, there was a systematic review done some years ago that looked at the evidence for whether postgraduate teaching in EBM changed anything. And what it found was that using out-of-practice teaching did improve knowledge. So those standalone workshops, they definitely improved knowledge, but the trainees really needed integration of EBM with clinical practice to improve their skills and their attitude. So in order for people to actually take that knowledge and put it into practice and want to use it, we really need to be getting them to do that during their training in practice, not just at the workshops. And there's been a recent body of work in the Netherlands that's been looking at how this actually takes place in the real world in general practice. And they got a group of GPs together into a focus group to brainstorm some ideas. And this is a fairly recent paper. It's quite good. You might like to go away and have a look at what that has to say, see what some other GPs from the other side of the world have got to say about this. And they were trying to show how learning conversations with your registrar might form the backbone of this process of teaching evidence-based medicine as well. So the traditional way that we used to teach evidence-based medicine was using this 4A's model, or sometimes it was a 5A's, and they added an evaluation step at the end. But we used to teach this. We used to teach people that you have to ask a question and you have to use a particular framework, med search, and we used to teach everyone how to put together a good search strategy, and then we do critical appraisal. But what tended to happen was that the training focused really on the first 3 of these steps and didn't spend a lot of time talking about how you actually apply it to the patient. And I think we all agree in general practice, that's probably the real skill, is working out how we actually put this into practice with our individual patients. It can be a real challenge to get your head around those first steps, and we're going to talk about some changes, recent changes in the approach to this. But I think the first step is still important. So we still want our registrars to be asking questions, and we still want to be trying to find some answers with them. And our registrars do need to have some skills in thinking critically about that evidence. And that might mean they need to know how to understand the strengths and weaknesses of different types of research. They might need to know how to read and understand certain statistical terms. But they also need to how to communicate what they've read and understood to patients as well. And they need to know when to apply it and how to apply it. So one of the questions we got on registration, which I thought was great, it said, well, should we be using EBM day to day in our clinical practice? And they gave the example, should we be checking troponin in any chest pain as an outpatient? And so I thought this was an excellent example of how a question might come up just in discussions with your registrar. I've got a patient with chest pain, should I send them to hospital or should I check their troponin because their chest pain seems to have gone away? And it's one of those examples where we've probably been taught something for a really long time, but we've probably never really known what the evidence for that is, or we might wonder whether anything's changed. So encourage your registrar to ask questions. And a little bit of a teaching tip, if a registrar does ask you for clinical advice, so this is one of those examples where you're actually using EBM all the time without you or your registrar realising it. So if they ask you a question, should I check troponin in this patient? Then I encourage you, rather than just giving them the answer, that once you've given them the answer, you either use the word because and tell them what evidence you're basing it on or how you're applying it to this particular patient. I would do this because this paper or this guideline or this source of evidence recommends it. Or you might say, I do this because even though this guideline says in this particular patient, these factors mean we shouldn't go down that path. Or if you're not really sure what the evidence was, then say but. So I wouldn't check troponin in this patient because I was always taught that, but I'm not sure if the evidence has changed. So let's go away and try and find some information about that. And so that's one way that you can incorporate evidence-based medicine just into your day-to-day clinical supervision, being really explicit about the way you're using evidence and how you're applying it to the patients and actually telling that to them. Or if you're not really sure what the evidence is, using that as a learning opportunity and both going away to try and find what the latest evidence says. So that leads us to the next point. What's the best available evidence and how do I find it? So as I said, traditionally, we used to teach people how to do a Medline search, and then that would bring up 500 papers, and then you had to try and work out, which papers you were going to use, et cetera, or try and filter them down. There is so much evidence out there these days that we actually need a different strategy to do this. And so many of you may have seen the traditional evidence pyramid, which has things like case studies or expert opinion on the bottom, and then goes all the way up to randomized controlled trials at the top. In the 1950s, it was estimated that the amount of medical literature doubled every 50 years. But by 2020, the amount of medical literature was doubling every 73 days. So there is absolutely no way that we can keep up and keep on top of all of the new studies and papers that are being published now. And so one strategy for us in clinical practice to make it more achievable or feasible to use evidence is actually using pre-appraised evidence. And this is an evidence pyramid which uses pre-appraised evidence instead. So we've got our unfiltered sources down the bottom, so cohort studies, randomized controlled trials, and then we've got a series of pre-appraised sources on the top, so things like systematic reviews and meta-analyses, or there might be articles that actually summarize a systematic review for you and bring it all together. Or there's clinical guidelines, evidence-based clinical guidelines, which have tried to take what all of these systematic reviews have said and put it into some sort of practical application for particular contexts as well. Under each level of the pyramid, I've just mentioned some of the tools, so some of the resources. People mentioned having resources. Sometimes what people mean by that is, well, I don't have access to, I might be able to use PubMed to do a search, but I don't have access to the full text. But things like Cochrane Library are freely available to all Australians, so that can be a useful resource. Some of you will subscribe to something like UpToDate. If you're a member of the RACGP, you have access to Dynamed through the Murtaugh Library, and some people will subscribe to therapeutic guidelines, and so lots of us will actually have access to some of these pre-appraised sources. If it's something you haven't really explored before, this is just showing you a couple of those tools. So Dynamed, which as I mentioned, you can access through the RACGP library. Trip Database is a free tool which gives you a hierarchy of the evidence, and I'm very briefly going to show you what a page might look like after you search, or something like Cochrane Clinical Answers, where it's trying to pull together the key information from a Cochrane review to answer a particular clinical question. So these might be some of the tools that we use in practice at the time that that question comes up. Should I be checking troponin in all my patients with chest pain? But we do need to be specific about what we want to know. So is it that we want to know if we should be checking troponin as a screening tool to see if we need to send them to hospital? Are we trying to use it as a rule-out tool to reassure ourselves that they aren't having an MI and that we don't need to do anything urgently? So it's still important to be quite clear about what question we have so that we go looking for the right information. So with these tools, I encourage you to have a bit of an explore and a play. It does take a bit of practice getting used to how to put together a few good search terms to use. So in this case, I decided that my key terms, the things I was really interested in, was chest pain in primary care. Because in this case, the setting is really critical to answering our question. If I just put chest pain and troponin, I thought I was pretty likely to get a lot of resources related to hospital care, when actually what we're really interested in is what we should be doing in primary care instead. Now, please don't try and read all of this. This is just like a screenshot of what you get in Trip Database when you type this into the search engine. And it's basically color-coded, so you can see which are the highest sources of evidence in green, and it moves down through blue and red and then to yellow. And so it helps you decide which piece of evidence might I want to go and look at. While it didn't give me any useful information for using with my patients now, what it did tell me was that there is actually a bit of research being done on this area. And so this might be an area which is going to change going forward. So we can actually see if these raise some questions about whether I'd follow the advice given in that algorithm or whether I needed to look for newer data and more relevant data. Is there enough information here to change my current practice, what I was already doing? I also got a question in the registration questions about what to do about complementary and alternative medicine. It's often harder to find good quality evidence for these types of interventions, but Cochrane has a page that curates all the relevant Cochrane systematic reviews and then groups them by type of therapy. So if you have questions about particular types of complementary and alternative medicine, then this is a great place to go to look for systematic reviews on them. But as I said, often it's a little bit frustrating because you read them and it basically says the evidence is too weak to make a clear recommendation. So once we've got the evidence, then we need to be able to understand what it says and we need to know whether we can trust it as well. So critical appraisal really comes down to, doesn't matter what type of study it is, it comes down to three big questions. Can I trust the evidence? Are the results important? And do the results apply in my situation? And depending on the type of study you're looking at, you'll ask more targeted questions on those topics. And there are heaps of really good critical appraisal tools, rapid critical appraisal tools available. So if critical appraisal is something that you feel like you need upskilling on, my top tips would be use one of the critical appraisal tools and just build up your skills, gradually add more and more of the questions that they suggest, and doing it in a group usually really helps as well. So, can I trust the evidence? Basically, this is about looking for bias. I said earlier that even though we were using these pre-appraised sources where someone else had kind of done all the hard work of filtering out the good stuff, we still need to critically think about the papers. We need to be weighing up their strengths and their weaknesses. And critical appraisal basically comes down to weighing up the strengths and the weaknesses of each piece of evidence that we look at. And that can be a really in-depth, involved process, but it doesn't have to be. It's something that we can actually do reasonably quickly with practice. So the first question we have is, can I trust the evidence? And that's basically looking for types of bias in the paper. And there's a whole different types of bias. So is the population similar to the type of people I would expect to have this problem? Have they been randomized properly? And then there's measurement bias. How have they actually measured the outcome? Do I think there's a risk because it was the patient filling in the measurement tool at the end? Was there recall bias because they were being asked about something that happened 6 years ago? The second question we ask ourselves when we're reading a paper are the results important? So we need to be able to understand what the results are, but we really want to know, how big is the effect? Is it a significant effect? We also want to know how precise the results are. And so how sure are we that the result that they got is pretty close to the truth? And then even if it seems to have quite a big effect, and even if it seems quite precise, we want to know, is that clinically significant? Does it actually make a difference to our patient? Sometimes the numbers look really good, but it doesn't really make much of a difference to our patients. You know, yes, this new antihypertensive might reduce the millimeters of mercury by 50%, but if that's only going from a reduction of 4 millimeters of mercury to 2 millimeters of mercury, then yeah, it's not clinically significant. So, and then we want to think about whether what we're reading applies in our situation. So are their patients similar to mine? Is their practice context similar to mine? We want to think about not just the benefits, but what were the risks? What were the adverse effects that were measured in the study? And we also want to think, well, how does this compare to existing treatments we've already got? It might sound really good, but if we've got something that's already good, why am I changing to use this new? There needs to be a good reason to change to a new treatment.
And I guess the alternatives also include non-pharmacological alternatives in many cases. There's the old adage, they don't have a drug rep for exercise, and the concept of whole foods, eating whole foods rather than eating sort of rubbish and then supplementing with multivitamins. So there's all these examples, I think, where there's stuff we talk to patients about all the time, which is their lifestyle. often can have, multiple times the effect of us putting them on a medication. That's not to say, of course, there's certainly many, many times where we do both at the same time because we recognise that lifestyle changes aren't as dramatic, but the alternatives often can be non-pharmacological.
Yeah. And the other thing that people sometimes find daunting about evidence-based medicine is understanding what all of those numbers mean in the papers. And I recently watched a really clear and concise video on this by Paul Glasziou on interpreting research evidence. It's available on YouTube, and he just gives a really brief run through from a paper, stepping you through talking about, well, what do all those numbers mean? How do you interpret them? So this can be a good learning opportunity. Sometimes your registrars will actually have more training in this than you, and it can be something that you can work through together. So as you've found a piece of evidence to a clinical question that you've had, you can sit down and just have a quick look at different parts of this. So you might sit down one time and say, well, do we think it's a good paper? Can we see any obvious sources of bias? And then you have a quick look at the results. And some of the things that you'll come up with will be, the relative risk. And so understanding what's the difference between a relative risk and the odds ratio. Also understanding the difference between relative risk reduction and absolute risk reduction. They're things that drug reps will often talk to you about. And they'll talk to you usually about the relative risk reduction. So, maybe deciding that you and your registrar are going to learn about what's absolute risk reduction and how do I work that out can be a really useful exercise for you both. But I really encourage you to look at Paul Glasziou's video on it. It's lovely and clear. We talked about, how precise was our results? How close to the truth are they? That's where we're talking about things like confidence intervals and p-values. And if we're looking at systematic reviews and meta-analyses, then forest plots might come in as well. But really often in general practice, we're very interested in that clinical significance. It might be statistically significant, but is it clinically significant? We're interested in what the adverse effects were as well as the benefits, and we're really interested in how it compares to the alternative treatments that we have or interventions we have at our fingertips. I mentioned some of the really useful tools there are. This is just a screenshot of some of them. It's the Centre for Evidence-Based Medicine at Oxford and the HASP project. Basically, if all the things on the previous 2 pages just made no sense to you at all, these tools step you through it all with examples. And so there's no way we could teach you everything there is to know about critical appraisal. So I'm more interested in pointing you where to go. The other thing, as I said, it's more interesting doing critical appraisal in a group rather than on your own. But it is important to be pragmatic. No study's perfect. You really want to be judging how important the bias is. Is the bias so significant, or are the weaknesses in the paper so significant that you're going to ignore what it says? So don't be too harsh, I guess, is the take-home message there.
And there are often increasingly a number of journal clubs available. I think your registrars tend to have them. I think throughout Australia, I think in every state they have journal clubs available. And that the journal club is really, when they tend to ask a question, look at 1 or 2 papers that might answer that question, and then ask the same thing Sky was checking before, is it a well-written paper? Is it relevant to answer the question in our patient? It wasn't available to us oldies when we were going through medicine, but certainly there's been a huge increase now. So I do encourage you to go along to 1 or 2 of these journal clubs or places where the person running it will just sort of guide people through. They won't give you the answers, but they'll sort of show you this is the sort of things it is worth thinking about when we're answering this sort of question. I think just getting that into your head really helps you the next time you read, your next 10 things you'll ever read, you think back to that journal club and think, what would the person running the journal club have asked?
So we've spent a bit of time talking about the evidence, but as I mentioned at the start of the talk, what's equally important is making sure our registrars know how to find out the patient's values and preferences, to understand the context you're in. You all work in very different clinical environments. Sometimes your registrar will come knowing exactly what to do in their large city metropolitan hospital, and they'll try and do the same thing in your practice in a completely different context. And so those areas you guys are complete experts in, and you need to show and demonstrate and model to the registrar how you're adjusting what you do with your patients because of those factors. And that's where that clinical judgment comes in. So when we think about combining evidence and patient preferences, we really break it down into three main tasks. So the first task is an evidence task where you're taking the trial data or you're taking the guidelines and then you're trying to individualize the evidence for your patient. Try thinking about how similar your patient is to the patient that these guidelines were designed for. The next one is that resource management. So do I have access to all of the things they're recommending in this guideline? Is it practical for my patient? Is it available? Is it accessible? And then we've actually got to communicate that to the patient. So your registrar needs to be able to think about all of those factors, and then they want to be able to discuss the options with the patient. They need to be able to explain the pros and cons of each of the options. They need to find out what's important to the patient and then help the patient come to a decision. Now, obviously, sometimes there isn't a choice for the patient. There's pretty much just one way to go, one best option for the patient. So it might be a case of that option or the patient opting out, but occasionally there will be different things. So Justin, you were talking before about sometimes we have alternative therapies we're already using, and we need to be able to clearly explain to the patient what their options are and what the pros and cons are. And this can be a really useful framework that you might like to use with your registrars and teach them. So it's the BRAN mnemonic. So you think for each of the options, what are the benefits of that option? What are the risks of that option? What are the alternatives? And what if the patient did nothing? And so that can be another teaching activity. So the registrar says, well, you know, the guidelines say this, and you can say, okay, tell me, what are the benefits for the patient? What are the risks? What are the alternatives? And what if they did nothing? A couple of tips when you're explaining results to a patient, particularly if it's statistics, try and use a consistent denominator. So if you say 1 in 3 patients get this, 2 in 5 patients get this, that can get really confusing. Whereas if you try and use this many patients in 100, this many patients in 100 for all of the statistics you're giving them, that can help make it more understandable. And visual aids can be really helpful when they're available. So there's decision aids that are sometimes available to us. And the advice is try not to use descriptive terms on their own for risk. So try not to say, well, this is low risk and this is high risk and this one's high risk and this one's medium risk, because those words mean different things to different people. You can use them, but try and then use a value as well. So to make sure that you're on the same page. And be aware that the size of the number that you give plays a huge role in how risk and benefit is perceived. So relative risk and relative risk reductions usually look a lot more impressive than absolute risk reductions. Using the example before, millimeters of mercury, if I say there's a relative risk reduction of 50%, that sounds a lot more impressive than saying there's an absolute risk reduction of 2%, even if they're actually exactly the same thing.
It is very difficult to communicate risk. One of the things we have to get good at as GPs is figuring out the literacy, the numerical literacy of the person we're talking to, don't we? Because, you'll get, if you're talking about risk to an engineer or something, a structural engineer, they're going to want numbers and stats. And if, I work in Aboriginal health, and there's a very different way of describing risk. And often you do have to sometimes just be general about it. And often I find, Sky, I don't know if they say it to you, but they sort of say to me, what would you do also, which I think is actually a very clever question on their part, although I don't know how you answer a question like that, Sky.
It's a difficult one to answer because I already know that my preferences and values are often somehow different to theirs. And so what I would do is actually not going to be necessarily what they should do. But yeah, I agree. I've had that as well. So this is just an example of how you might try and put some statistics from a paper into language that's a bit easier for patients to understand, but it also gives you an illustration of how the way you frame those statistics can look really different. So if you have a look at these 3 statements for, let's say we're explaining a new screening test to a patient, which of these 3 options would make you most likely to accept the screening test? So is it the relative risk, the RRR, the ARR, or the number needed to treat, the NNT? Which of these statistics would make you most likely to go ahead and have the screening test done?
Ours have it, I think.
That's right. And that's what tends to happen, that the relative risk reduction often looks more impressive and that you have a tendency to go one way or the other based on that. So it is important to be thinking to yourself, do I think the relative risk reduction gives a kind of true representation of what I'm trying to get across to the patient? So it can be a handy practice activity that you can do with your registrar. Say, okay, well, I want you to explain to me how you'd tell a patient about the benefits of this particular treatment. How would you tell a patient about the risks of this particular treatment? So as I said early on, there's no way that we can cover everything there is to know about evidence-based medicine. It was more about what are some of the ways you can build it into your day-to-day interactions with registrars. But if you want to learn more, it's going to depend who you are and where you are as to what you can access. If you're a member of the RACGP, there is a quite extensive learning module on GP learning that you can do called critical appraisal. So it's mostly about finding the evidence and critically appraising the evidence. But I think there are, Justin, you're involved in developing this one. Is there stuff on applying it at the end as well?
I mean, we do try to add in resources at the end of that. It's just a handy, it's on the GP Learning platform.
Great. Yep. So you'll only have access if you're a member of the college. The BMJ has a series of papers that are somewhat old now, but they're still very good, called How to Read a Paper. There was a whole series of them written by Trish Greenhalgh, and I can recommend those as a very readable way of learning about critical appraisal. And Dynamed, I noticed this little button that said EBM on the side, and when I clicked on that, it gave me a PDF document with quite a good summary, I thought, of overview of EBM, mainly using that 5A's sort of approach or 4A's approach that I talked about at the start. So that's just a couple of places. I also quite like, for just short explanations of some aspects of reading a paper, there's a YouTube site called Sketchy EBM, and I quite like their videos as well.
We're trying to move towards chance rather than risk, which is something new.
Okay.
I tend to say risk all the time, but
yeah, okay, that's good to know. I didn't mention that in the papers I was looking at about explaining risk.
probably all the dorky statisticians still love risk, but maybe it's more in the patient context.
Yep, no, I like it. Talking about chance. 1 in whatever chance of this. Sounds good. All right, so essentially my top tips for teaching in day-to-day practice is encourage your registrar to ask questions. And then when you're giving them an answer, either explain because and show them how you're applying evidence in practice, or say, but I'm not really sure what the evidence is for that. We should go and find the answers. Use pre-appraised sources rather than feeling like you have to go away and do a Medline search. But make sure when you get that pre-appraised source, you're having a look and you're thinking, do I think this evidence is fit for purpose? Is it answering what I need it to? Is it relevant to my patients and my context?
What is a pre-appraised source? What are you talking about?
Yeah, so that was that pyramid I talked about earlier. It's where somebody else has done the work of filtering out the best bits of evidence and then given you a bit of a summary of that. So it might be a systematic review like you find on Cochrane, or it might be an evidence-based guideline. That's what we're talking about. So sometimes people think doing EBM with their registrar means doing a Medline search or a PubMed search, but doing EBM with your registrar includes thinking carefully about health pathways, thinking carefully about therapeutic guidelines, thinking carefully about, all of those sorts of other sources that we use, not just looking at randomized controlled trials. It can be really good doing critical appraisal with your registrar using all of these fantastic tools that are out there. And practice discussing what you've read with your peers, discussing the strengths and weaknesses, what you think the strengths and weaknesses are. And you don't always agree with everyone around you. So you can have some quite good debates about different papers and guidelines. And then make sure that you're really explicit with your registrars just about how you are applying research in practice. So they don't just think that you're, doing everything on a whim, actually explaining to them, I'm doing this because.
Sky, I just do wonder if some people might be a bit anxious about discussing this with their registrars because, realistically, registrars are taught better by Ben Mitchell and the like these days about evidence-based medicine. And how about the risk to sort of embarrassment or, just an unease? If we're talking about our favourite topic as a GP, we're on solid ground, and then suddenly we're sort of exposing ourselves to something where we don't necessarily know all the terms as well as our registrar
Yeah.
know.
So I think having the confidence that you do actually know a lot about the 2/3 of that model of evidence-based medicine, that the understanding the patient preferences and the context, and you're actually really good at applying guidelines in a way that's appropriate for your patients. So that's the bit that you're really good at, and that's the bit that the registrars usually aren't. So it can be helpful to let the registrar tell you about the evidence part of it, and then you can ask them, okay, well, how about, how does that apply to this particular patient? Are there any problems with that? Is that something that's practical in general practice rather than hospital? So I think leaning on the things, because as I said, those are things that our registrars really need to do. Or if they understand the statistics and the research, you say, okay, I need you to explain it to me like a patient. I pretend I'm a patient, and now I want you to tell me what that actually means. And that has the advantage that you'll be learning at the same time what it actually means, even if you didn't understand the abbreviations and the acronyms.
I think that's great. And that does go back to your Venn diagram of the three things you showed at the start. Part of the evidence-based practice, I guess you would call it, part of that is, knowing how to analyse the stuff from the trials. And there may well be situations where your registrar is more familiar with that because they've just read the trial. But then happily for us, we've got the other Venn diagram, which is, clinical experience. And the other thing is likelihood. See, a lot of these things do depend on statistically, we'd call it the pre-test odds of something. But in practice, what that means is just knowing our population, what's common and what's uncommon. So I think that's the other advantage we have. And certainly a registrar coming out of the hospital system, they have a very different view of what things are, what's likely, what's important. Because, for them, chest pain is everything about, it's either your heart or it's a pneumothorax or else go and see your GP. And we're very good at the other stuff, which is go and see your GP. So, and they are probably, someone who's come out of a year in ED is probably going to be better at knowing. They'll be able to flick out stats about troponin that we won't know, but then we can add that other context. And I would like to thank Sky for your making EBM interesting. So thank you, Sky.
Thank you.
Have a good evening.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.